Welcome. My name is Andrea Wong, and I'll be speaking today about surgical approaches to nasal obstruction. So, nasal obstruction is one of the most common symptoms of nasal pathology, and one can define it as a sensation of a lack of airflow in the nose with inspiration or expiration, and it can be unilateral or bilateral. It correlates with the decreased quality of life, and patients may also use terms such as nasal congestion and/or nasal stuffiness to describe nasal obstruction. So, common causes of nasal obstruction may include septal deviation, turbinate hypertrophy, nasal valve collapse, adenoid hypertrophy, and nasal tumors or polyps. We can classify it in terms of objective and subjective findings. So in terms of objective nasal obstruction, you may see mucosal inflammation, which can be caused by allergic or non-allergic rhinitis, chronic sinusitis with or without nasal polyps. Anatomic variations are a very common cause, including septal perforations, deviated septums, inferior turbinate hypertrophy, nasal valve collapses, and choanal atresia. And finally, nasal masses can cause nasal obstruction, and some may include benign and malignant masses, congenital lesions, infectious processes, and autoimmune etiologies. Subjective nasal obstruction is when the patient describes a sensation of poor airflow, but there is no identifiable anatomic or mucosal abnormality. One possibility is that the patient is experiencing a nasal cycle. So the nasal cycle is a spontaneous congestion and decongestion that alternates between the two nasal passages. And it occurs in about 80% of the population, and it repeats every half an hour to 3 hours. And patients will come in and say, sometimes I breathe better from one side, and then I lean when I'm lying in bed and I turn to the other side, then my other side opens up. And this may just reflect the normal nasal cycle. Vasomotor rhinitis is also another cause of subjective nasal obstruction, where you may not see anything on examination, but the patient says, well, when it gets humid outside or I eat something spicy, my nose becomes stuffy. So we want to get a good history of present illness, and this will include getting information about the duration of the patient's symptoms, what other complaints they have, including facial pain or pressure, loss of smell, sneezing, itchy eyes, epistaxis, headache, changes in vision, which may help you zero in on an infectious cause or tumor-like cause. You want to get an idea of whether or not it's a one-sided problem or a bilateral problem, what inciting factors there are, getting a history of the patient's allergies, seasonal or perennial allergies, a history of nasal or facial trauma, identifying other medical and surgical treatments, including previous nasal surgery or rhinoplasty, comorbid conditions including snoring, obstructive sleep apnea, smoking history, and systemic complaints will allow you to better identify the cause of their nasal obstruction. On examination, looking at their external appearance, you want to note any gross deformities, including a deviated nasal dorsum, poor nasal projection or rotation, issues with maybe a saddle nose deformity, looking at external nasal valve collapse, and looking for any skin lesions or scars from previous surgeries or skin cancer removals, for example. The external nasal valve collapse, you just want to watch them while they're breathing and notice whether on inspiration they have any collapse of that nasal valve. Also, you want to look at the side walls and see if they collapse during inspiration. On intranasal exam, you want to pay attention to the septum. Is the deviation that you see in the caudal portion, or is it more posterior? Is it along the floor of the nose or more superiorly? Are the turbinates enlarged? Is the mucosa boggy? You want to look at the internal nasal valve and see if that is collapsing. And also looking for gross abnormalities such as polyps and masses and other asymmetries. So airway resistance follows Poiseuille's law, whereby the airflow resistance is inversely proportional to the fourth power of the radius. Or more simply put, a small decrease in the cross-sectional area of the nasal valve will lead to a large increase in airway resistance and perceived nasal obstruction. So turbulent flow also creates a perception of increased resistance and a sense of low airflow. A deviated nasal septum is very common. It often results in a unilateral airway obstruction, but depending on the degree of deviation and whether or not you have a superior deviation in one direction and then an inferior deviation in the other direction, you may actually get bilateral symptoms. It may be related to birth trauma or direct trauma, such as falls or motor vehicle accidents or getting hit in the face with a baseball. I also suspect that in a lot of children, falls at a young age, like in toddlerhood when they're trying to learn how to walk, may cause the quadrangular cartilage to maybe separate from the maxillary crest, or because the cartilage at that age is so soft, it may create a small fracture that then, as they grow, becomes a more prominent deviation. You may notice in cases of septal deviation that the turbinate on the opposite side of the septal deviation is hypertrophied. With inferior turbinates, you can define the hypertrophy in either the mucosal portion of the inferior turbinate or in the bone. In mucosal hypertrophy, it typically is bilateral and it improves with decongestion. This affects our ideas for treatment. So for mucosal hypertrophy, you would want to treat the patient medically first and surgery if there is no improvement. In bony hypertrophy, the patient will not really have much improvement in their breathing with decongestion. So medical treatment is not as helpful. Surgery will be more helpful in cases of bony hypertrophy. Usually the patients have a bit of both mucosal and bony hypertrophy. With turbinates and low septal spurs, this can largely affect airflow because 50% of the air passes along the floor of the nose. So look at the floor of the nose when assessing for nasal obstruction. So the internal nasal valve is defined as the narrowest portion of the nose. You're looking at the angle of the septum, the upper lateral cartilage, and the anterior head of the turbinate, of the inferior turbinate. A normal nasal valve angle in a Caucasian nose is 10 to 15 degrees. In an African American nose or in an Asian nose, it's going to be wider than 10 to 15 degrees. The external nasal valve is essentially the opening to the nostril and composes of the space that is exposed around the lower lateral cartilage and the crura of the nose. A caudal maneuver can be performed to assess if the nasal valve is an issue. So a caudal maneuver generally is when you place a few fingers on the cheek, just lateral to the nostril, and then you retract the skin laterally, and this will widen the external nasal valve and the internal nasal valve, and the patients generally feel that they breathe better. A modified caudal maneuver can be helpful in determining to what degree this makes a difference. So using a curette or the wooden end of a cotton swab, you can lateralize the external nasal valve or the internal nasal valve and occlude the opposite nares. First, have the patient breathe with one nair occluded and have them give their airflow, a rating of patency. Usually I tell patients between 1 and 5, 1 being not able to breathe through the nose at all, and 5 being 100% patent. And then have them do it again while you perform a modified caudal maneuver. That will give you an idea of how much the nasal valve is playing a role in terms of their nasal obstruction. So let's talk about surgeries to correct nasal obstruction. So the septoplasty is commonly performed, and in this procedure we are removing the deviations from the cartilaginous and bony septum while attempting to preserve the existing structure. So there are two main incisions. The Killian incision is an incision made 1 to 2 centimeters posterior to the caudal margin, and the hemitransfixion incision is made at the caudal border of the cartilage. And so once your incision is made, you will develop a mucoperichondrial plane along the side of your incision, and once you've reached the bony cartilaginous junction, you can make an incision in the cartilage and elevate a plane on the opposite side. You want to make sure that your cartilage incision is roughly 0.5 centimeter to 1 centimeter posterior to your mucosal incision, So on the chance that you have a perforation on both sides, it won't be at the same level. One of the keys to performing a successful septoplasty is maintaining a dorsal caudal strut of roughly 1 to 1.5 centimeters. This will prevent issues with with nasal tip collapse and saddle nose deformity. And again, the goal is really to remove the deviated portions of the bone and cartilage. The decision to place cartilage back into the pocket is dependent on the patient situation as well as the surgeon preference. The internal nasal valve is usually addressed surgically with either spreader grafts or a flaring suture. In spreader grafts, you're taking a piece of cartilage, usually from the septum, that's fashioned to be placed between the upper lateral cartilage and the septal cartilage. So plane has to be developed between those two areas. And once you've tucked the spreader graft into that angle between the upper lateral cartilage and the septum, you have essentially created a slightly larger internal nasal valve as well as stabilize that angle. One way to think of it is the spreader graft is sort of like a sock that you've placed into a door hinge. And once that sock has been placed, you cannot close the door. It keeps that door slightly open. So once the spreader graft has been placed between the upper lateral cartilage and the septum, that angle should not collapse on inspiration. Flaring sutures are usually performed during rhinoplasty and by placing cartilage on the external surface of the upper lateral cartilage and fashioning your sutures in a caudal direction. The internal nasal valves are also widened and stabilized. External nasal valves are generally addressed with a batten graft, which is a piece of cartilage that's usually fashioned in an oval or tear-shaped and placed into a pocket along the piriform aperture, stabilizing the lateral external nasal valve. So inferior turbinate surgery has been practiced for many years, and there have been many different techniques described for reducing the inferior turbinates. Turbinectomy, defined as either total turbinate resection or partial turbinate resection, is one surgery. Turbinoplasty, where a submucosal resection of the turbinate is performed, is another procedure. More recently, a mucosal ablation has been performed with either electrocautery or laser, and submucosal reductions are another surgery performed with either electrocautery, radiofrequency ablation, microdebrider. And finally, a turbinate lateralization is a procedure that's usually performed with the above four reduction procedures. So turbinectomy may be total or partial. The total turbinectomy has fallen largely out of favor because of reports of empty nose syndrome and atrophic rhinitis. So the theory is that in total turbinectomy, when the entire mucosal surface has been removed, the patient lacks sensory airflow. So even though objectively the nasal cavity is much larger, the patient does not perceive airflow as they breathe in and out. It can also lead to a lot of crusting, bad odor, dryness in the nose. Partial turbinectomy was basically an adaptation of the total turbinectomy, where only the anterior head of the inferior turbinate is removed, and this can be performed with either scissors or microdebrider. Some complications may include more bleeding, crusting, and scar formation due to the amount of tissue that's removed. Turbinoplasty is essentially a septoplasty that's performed on the inferior turbinate, so that an incision is made along the head of the turbinate, and a mucosal plane is elevated, whereby the bone remains in place, but the mucosa overlying the bone is elevated. Then the bone itself is dissected out inferiorly and removed with scissors, and then the remaining mucosal flap is sort of tucked underneath the remaining bone. As you can see here, the mucosal incision was made, a plane was dissected and a rongeur is used to remove some of the bone. Turbinoplasty is very effective, but it can be a little bit time-consuming, and bleeding and crusting may still occur. So mucosal ablation is when electrocautery or laser is used to coagulate the tissue of the inferior turbinate. That coagulated tissue will shrink in size, and the scarring that occurs will will result in further tissue reduction. The benefits of this is that it's something that can be done in the office with local anesthesia and decongestion. However, the effects may be short-lived, and repeat cauterization or laser are often required. Submucosal reduction is a relatively newer procedure, and it was developed to essentially preserve mucociliary function and with less bleeding and crusting as compared to turbinoplasty. So this can be performed with either submucosal electrocautery, radiofrequency ablation, or microderbrider. Submucosal electrocautery would be placing a spinal needle or a bipolar into the mucosa, so into the submucosal plane, and then coagulating the tissue. The temperatures can get as high as 750 to 900 degrees Celsius. Radiofrequency ablation can result in temperatures as high as 60 to 90 degrees Celsius, and microderbrider is just shaving the tissue away, so no elevation in temperature. So this is a diagram showing a submucosal turbinate reduction performed by microderbrider. The microderbrider is introduced into the turbinate, and the blade is rotated in 360 degrees to be able to microderbride the submucosa as well as the bone. This is usually accompanied by a lateralization of the turbinate, and this can be performed with a Freer elevator or Goldman bar, and the turbinate can be infractured and then outfractured. The lateralization procedure can be performed with any of the submucosal reductions, or the mucosal ablation, or the turbinoplasty. So what are the outcomes? So in 2003, Pacelli performed a randomized trial of 382 patients comparing 6 techniques: the total turbinectomy, laser cautery, electrocautery, cryotherapy, submucosal resection, which is the turbinoplasty, and a submucosal resection with lateralization. The patients were followed for 6 years, and only the submucosal resection with and without the lateralization resulted in a long-term patency and mucociliary clearance after 6 years. So this highlights the importance of maintaining a intact mucosal layer. So what about radiofrequency ablation compared with microderbrider? So in 2009, Liu performed a prospective randomized trial of 120 patients comparing long-term results of radiofrequency ablation versus microderbrider. Improvement in the visual analog score, anterior rhinometry, and mucociliary clearance at 6 months and 1, 2, and 3 years were seen in the microderbrider group. The radiofrequency ablation group had improvement from 6 months to 1 year, but no further improvement, with a gradual return to baseline at 2 to 3 years post-op. So to summarize, while we have many different techniques for inferior turbinate reduction, it seems that the submucosal resection via either a turbinoplasty or microderbrider approach tend to have the longest lasting results. But given that many ENT procedures are performed in the office, there may be a role for performing a radiofrequency ablation, which can be done more easily in the office because there's less bleeding, or electrocautery. We may come up with the following algorithm, where for a patient who has bilateral inferior turbinate hypertrophy that's largely mucosal and who does not require a septoplasty, one may start with an office-based, minimally invasive technique such as laser, electrocautery, or radiofrequency ablation. And if that succeeds, great. But if it fails, that patient may then require partial turbinectomy or microderbrider submucosal resection or turbinoplasty performed in the operating room.